Hello, everyone. Prosthodontics on Friday. I am Professor Cho In-ho, moderator of the program. This is the third episode. Dr. Park Jong-hyun of Seosan Dental Clinic will talk about impression taking to fabricate accurate and aesthetic prosthesis. This is broadcast live. You may leave your questions on the YouTube freely. We will try to answer the questions during Q&A session. Thank you very much for your participation. Let me introduce Dr. Park Jong-hyun. Please don't touch your channel. Hello, I am Dr. Park Jong-hyun, Seosan Dental Clinic. I would like to thank Professor Cho In-ho for having taught me a lot with a smile on his face, and also Dental TV for inviting me over to this program. Today, I'm going to talk about impression taking to fabricate accurate and aesthetic prosthesis for dental implants. This is the content. I would like to show you the impression taking technique that I use quite a lot. These days, with the use of guide, placement positioning has improved, and we use stock abutments more and more. If we can use the stock abutment without modification, I prefer to take impressions up to the visible margin. Like impression taking of natural tooth, abutment level impression taking, if there is a subgingival margin, it's difficult to take the impression. In this case, I would like to merge the model scanned image of the same size stock abutment with gypsum model scanned image. I have about 10 stock abutments that I use frequently, and if I model scan them once, they can be brought in and used repeatedly. Even though the impression is taken only for the visible part, the subgingival margin image has been acquired using the merge. The final prosthesis is completed. I don't like to prepare or modify the stock abutment intraorally. If a stock abutment needs to be prepared or the implant position is not very good, I prefer custom abutment level impression taking. Let's talk about the proper impression taking in the posterior region. Pick-up impression coping, transfer impression coping are well known to many dentists, so I'm not going to talk about that. Impression coping, when you use it, proper connection of a hex is the most important thing. There are 4 X-ray images. One is not correct. Which one is that? It's the first one that's not connected properly. OSSTEM impression coping has a notch. If notch is away from the fixture like this, it is not connected properly. Even though hex is not aligned, the screw can be tightened. So if it is tightened that way, error is made. If you look at here, the Morse tapered connection has a gap. A case, clinical case. For the pickup impression, you need to make a hole in the pickup tray, indicated by the arrow. To remove the impression, you need to remove the screw first. 1 feet abutment is fabricated with a gypsum model, and the final prosthesis is also fabricated together. When the crown is very short like this, to increase the retentive power, I like to use the cast restoration. For this, analog is better than the digital approach. To increase the retentive area, fixture level impression is preferred in this case. For better subgingival margin fabrication, Transfer impression coping. Clinically, I use this quite often. When I use it, the impression should be taken by blocking the driver hole. I will elaborate on that later. Some say transfer coping is not very fitting. I can see they take impressions without blocking the driver hole. The red circle shows the hole is blocked out with the utility wax. If it is not blocked out like this, the impression is taken up to the driver hole. Because of that, the impression coping cannot be seated properly, fully. Magnified image. Can you understand that? The driver hole is not blocked out when impression is taken, then the errors will increase. I use utility wax to block it out. A clinical case. A dentist needs to connect the transfer coping and take the impression with the closed tray. Everything else will be done by a lab. Abutment is chosen, modified, and the final prosthesis is fabricated in discussing with a lab. Abutment and the prosthesis fabricated on the gypsum model is transferred to the mouth and everything is finished. One more error that we can make easily is using another company's incompatible internal conical type products. Many of other companies' screws are very long. I'm not saying they are wrong. Companies have different lengths. This part indicated by the arrow should be empty to be connected properly. If the screw is long, interference at the bottom can occur. Original products can be connected properly, but if other company's product is used with OSSTEM, interference at the bottom can occur. The interference can lead to the gap near the Morse tape portion. The problem occurs often with a short implant. Diameter 6.0, 7.0. Other companies' products, when they're used with OSSTEM, bottom interference can occur. For TS product 8.0 and longer, the bottom interference doesn't occur when other companies' product is used together. If high-OSSTEM products of the US is used, the bottom interference can occur. So you need to check the compatibility with other products. The same is true for the skin body. If you do not check the compatibility properly, errors can be resulted in. For the fixture level impression taking, if you get rid of the errors in the hex connection and the lap errors, everything will be okay. But 5 different connections can generate errors. If you do it properly, no problem. But if you make a small mistake in any of these, errors can be made. If you fabricate abutment and crown using the fixture level impression, the bite registration is the most challenging part. After connecting an abutment, if you take an impression like you take the impression of a natural tooth, that is easy to do for both a lab technician and dentist. It's the best way to generate good outcome easily. However, with the introduction of digital scanning, connection transfer occurs only 2 times. The chances of making errors is reduced. Let's look at a clinical case. As the maxillary second premolar is fractured under the bone, immediate placement is planned, and it is performed. Right after the implant placement, after 3 months, distal scanning and abutment crown design was done together. OSSTEM fabricates 1 feet abutment. In the lab, zirconia crown is fabricated. As they are fabricated at the same time, the time is shortened quite considerably. The first prosthesis fabricated. It shows proper contact with the adjacent teeth and good occlusal relations. Next clinical case, if you take stock abutment level impression, the gingiva is irregular, so subgingival margin would remain, which is not properly registered. Let's talk about how to deal with that problem. Abutment remains connected, the same size stuck abutment. Another stuck abutment is selected and positioned in the impression body, and impression material is added at the margin. Abutment is removed and stone is poured. The margin is exposed totally, so any lab technician can fabricate easily. To fabricate a cast restoration, this type of model is needed. When I do the implant case covered by the national insurance using stock abutment, I use this quite a lot. The metal crown is properly restored up to the subgingival margin. I'm going to talk about the technique that can be done by anybody easily. This alone can handle all the posterior implant cases. It can be applied in all posterior cases. Transfer impression coping is connected. The first impression is up to the fabrication of 1 feet abutment and a temporary. While a temporary is used, even though they have not been seated properly because of bone or soft tissue, the problem can be resolved by the temporary use. Abutment sinking can be induced by the occlusal force. Abutment is connected to the fixture. Direct impression can be taken through the process. Fixture level impression taking process errors and abutment connection errors are all offset. Supramargin is set. Using the abutment level impression or scan, the final prosthesis is fabricated. A clinical case with a fixture level impression, 1 feet abutment is fabricated and connected, and a temporary is used for a while. Direct impression is taken. On the gypsum model, zirconia crown is fabricated. The final prosthesis is completed. The disadvantage of this approach, even though the prosthesis has a supragingival margin, not all abutment margin can be registered because soft tissue grows while the temporary is used. If there is a subgingival margin, the margin tends to be short like this. As the abutment and crown are not simultaneously fabricated, the transition area is not natural like this in many cases. As they are not fabricated at the same time, the space distribution is not done properly, so the shape would not be very good. But subgingival margin remains and the margin can be short. However, most importantly, the fixture abutment connection can be made much more stable from the use of a temporary, and the lab technicians are very familiar with this. Even though you do not have a lot of experience, this is very easy to do. You will have less problems of sitting, internal fit problem, occlusal fit problem, or frequent modification of contact with adjacent teeth. Anybody can do this pretty easily. I believe this is a pretty good approach. Another clinical case, the bone width is very narrow. Asset kit is used to expand it. 2 TS3 non-hex fixtures are placed. The buccal bone is very narrow, so additional bone graft is done. Due to lack of residual bone, a little bit buccally, the implants were placed. It is difficult to use the stock abutments. Fixture level impression is used to fabricate the custom abutment and PMMA temporary crown. The temporary has a little low occlusion and the contact with the distal adjacent tooth is not strong enough. It is corrected with adding resin intraorally. If the lab fabricated temporary occlusion and the contact with the adjacent tooth was appropriate, the final zirconia prosthesis would be made with the same design and delivered. As the temporary was not satisfactory, 1 month later, the gap with the opposing teeth and adjacent teeth were checked and abutment level scanning is done. The biggest advantage of the digital scanning is we can accurately measure the gaps. I'll show you how to scan subgingival margin. I always ask the lab to model scan after custom abutment is milled before it is sent to me. Before it is connected intraorally, I merge it with the scanned image. Do you have a rough idea of the merging process? The subgingival margin data scanned in advance is brought in and merged. We scanned only the visible part. However, subgingival margin image is acquired through the merging. Final prosthesis is completed. Abutment is fabricated first and abutment level impression taking is done. Due to improper distribution of the space, the appearance may not be very good. When we design the abutment, when the temporary is designed together, the custom abutment is fabricated considering the final prosthesis. Therefore, abutment level impression can provide a satisfactory outcome. Another clinical case, stock abutments are connected and scanned. This is a similar story. If subgingival margin is scanned at the abutment level, it is not easy. Only visible part is scanned. If the abutment is not modified, the image of the abutment of the same size scanned before is merged. As long as the diameter of the crown abutment and the height of retentive area is the same, everything else will be the same. Gingival height can be ignored for the merging. Subgingival margin image is very easily acquired as the patient has anterior deep bite. Mounting on the gypsum model would not be easy, but as long as the central relation is stable, the bite can be registered. Final prosthesis is fabricated and almost no occlusal adjustment. Only the visible portion is scanned, but appropriate margin is acquired through merging. Bite impression coping. You can think of it as a short transfer impression coping. Select a specification to leave 1 or 2 millimeters of bite space, and then impression is taken. With a bite tray, just like using the transfer impression coping, impression is taken and lab analog is connected in the impression body, and the abutments and the prosthesis are fabricated together at the fixture level. This is not good when intraocclusal space is too short. If the impression coping is in the occlusion with the opposing teeth, big error can occur. Therefore, it is very important to select the specification 1 or 2 millimeters away from the opposing teeth. The abutments are connected. Final prosthesis is tried in. I heard many times that the bite impression coping fits better than the transfer impression coping, and I was wondering why that is so. I believe that is because there is no driver hole, therefore there is less chances of making errors. If you take an impression after blocking out the driver hole of the transfer impression coping with the utility wax, I believe the two will generate similar results. Next, fixture level scanning. For the top-down process plan, guide design is done first. I have not tried it a lot, but it looks like it has advantages. The abutment and crown are designed at the same time, so it has better shapes. In the past, the abutment is model scanned or oral scanned first before final prosthesis is fabricated, so it took a lot of time. Now, the abutment is milled at the same time the final prosthesis is fabricated, reducing the time. considerably. The abutments arrive from the OSSTEM one-feet milling center through courier, and the final prosthesis comes from the lab. If you have the milling machine in your office, you can restore at lower cost and faster. If you use the OSSTEM one-feet milling center, you need to send with a mark of one-step prosthesis. It is a little bit different from the conventional method. You need to think of it as natural tooth preparation for zirconia crown. The difference is that you need to design the shape that can be reproduced by both custom abutment milling machine and the zirconia milling machine. If you look at the picture, you'll understand it better. Avoid sharp angle. Design the margin with the round shoulder, and the occlusal part of the abutment needs to be designed in a simple way for better fitting. This picture depicts the OSSTEM design guide. Please refer to this in designing the custom abutments. Next, what is the proper impression taking method in the anterior case, where subgingival margin is important? For the cervical shade, the thickness of the ceramic passing through the gingiva is very important, and it should be 1.5 millimeters or more. As the lateral has small space and a small tooth, it is difficult to design a thick margin. But if the margin is set subgingivally, you can get a proper cervical shade even though the margin width is thin. With the one-feet abutment, the abutment is designed to be thin to secure the margin width. The space in the lateral was too small. It is not visible here, but the labial margin width at 1.5 millimeter below the gingiva might be less than 0.5 millimeters. If the labial margin is at 1.5 millimeter subgingiva, 1.5 millimeter thickness at the gingiva passing area can be secured. The full zirconia prosthesis for the abutment with thin margin, the abutment's metal shade would not show, and the cervical shade will be appropriate. The margin is deep like this, full sitting cannot be made. If you use the ER-type prosthesis, which can be removed and put in again, ER-type prosthesis would be favorable for the anterior region. As for the cervical shade, if the margin is too thin, opaque can be used like this, but if the margin is too thin, opaque can be showing. So one of the two needs to be selected. If the margin is not deep, the width of the margin should be as thick as possible. If the thickness of margin is not sufficient, it should be at a deep level. To make it deep, I think the fixture level impression is better than the abutment level. Another clinical case, it is properly placed palatally. ER-type prosthesis can be used. If the stock abutment is modified, the margin would get thinner. In that case, for the cervical shade and for the contour, we need to have the margin subgingivally. And it is not easy to take impression up to 1.5 millimeters below gingiva at the abutment level. So I hardly use the abutment level impression for the anterior. Fixture level impression is taken. In this case, mostly in the anterior region, I use a PFM prosthesis. I'll tell you the reason a little bit later. If ER-type can be used, zirconia prosthesis can be used, but I use PFM more. Let's summarize. If ER-type can be used, set the lingual margin at 2 millimeters subgingivally. Using a stock abutment, the prosthesis shape can be adjusted to make it similar to a natural tooth. However, if ER-type cannot be used, the story is different. The stock abutment has very narrow margin. For cervical shade, in general, we need to go deep. If ER-type cannot be used, it is difficult to remove the cement after removing it, so I use the custom abutment as much as possible. For the anterior region, if the implant is not to be covered by the insurance, using a custom abutment seems to be more favorable. In the past, customized impression coping, I learned about it when I was a resident. The coping is fabricated using the pickup impression coping. It is customized to take impression. That is the standard way. I know this is good. However, I don't utilize it clinically because it is complicated. So mostly I use transfer impression coping to take impression. Let's take a look at a clinical case. Abutment level impression is taken, which I don't do often today. As you saw before, using the merging, subgingiva margin is acquired. Rather than using an intraoral scanner, if you can create good shade using monolithic zirconia, we need to use a model. As I cannot utilize the full zirconia in the single cases in the anterior region, I use the gypsum model, the analog approach, as much as possible. Next, insurance implants. If you scan the insurance implants, this is the only way. It is designed, the wax pattern is milled, metal occlusion contact is fabricated. The problem with the digital approach is that you cannot accurately know the space for ceramic for the PFM prosthesis. This went a bit too far, but this is used in this case only. Mostly, I prefer to use the impression coping or like this. I use the abutment level impression taking. I realize the limitations of stock abutment, but for insurance implant, I utilize the stock abutment. That's my protocol. This is a little bit regrettable, but if you use the stock abutment, this is inevitable. Here, the contact with the adjacent tooth is too strong, so the margin cannot be fully seated. If you adjust the occlusion in this case and put it in, the margin will not fit. So if you check the X-ray for the fitting of margin, occlusal adjustment will be reduced. Placing an insurance implant in the anterior region, there are many difficulties. The stock abutment needs to be used. If SARP cannot be used in a case like this, for proper contour, subgingival margin is advantageous. Like this, the sitting becomes very difficult. Therefore, I prefer to use a supramargin even palatally. I will not talk about cementation. I believe abutment level impression is very good. If it is not visible behind the lip line, even in the premolar area, we don't need to take too much effort for the prosthesis. On the abutment level, when we do the scanning, when it is modified, it is difficult to do merging. Using this stock abutment, it is not easy to make it all subgingival margin. So this is not a very good approach, but there are other advantages. If you take impression with abutment connected, it is easy to take the impression, so it is free from mandibular fracture. I believe this can be used easily by anybody. Summary. Hex connection is rather tricky, and many people don't realize the errors in the connection. Often the connection errors are observed in tricky places like number 7 or in a narrow place. It's relieving if we can take impression without the abutment connection problem. If an abutment is connected first, then impression is taken. If you use the model for superstructure, you could make a mistake in the space distribution. But if the fixture is connected to the abutment properly, no fatal problem will occur. For a full mouth case, creating so much space all at once is very difficult for me. So I complete one side first. On the other side, I restore up to the temporary and observe. If the patient adjusts to the situation, then I restore the other side with abutment level impression. But with the development of digital technology, much more predictive implant procedure is expected. After oral scanning, prosthesis is fabricated using one step. In the future, the digital scanning will be used more widely. Thank you very much for your listening. Thank you for the excellent lecture. Thank you. Dr. Park, I enjoyed your lecture on this prosthodontics on Friday. What's your impression of your lecture? Through the dental TV, famous doctors and professors delivered the lectures. And looking back on my cases to prepare the lecture, I realized I need to learn more and I need to work harder. Let's get started with the Q&A session. In your lecture, you talked about the impression coping. There are two types, transfer and pickup type impression coping. The pickup type, the advantage of that is that we can get accurate impression and accurate prosthesis. However, there are more cumbersome steps. We need to make a hole in a tray, and then when the impression material flows out, we need to cut that out. And after it is hardened, we need to check whether the screw is removed. Sometimes when we pull out the screw, the impression body can be torn, and various difficulties can occur. How do you check or recognize the complete loosening of the screw? As you mentioned various problems, actually, I don't use the pickup impression coping except in the anterior region. I used it a lot when I was a resident. As I remember it, the best way is as soon as the impression is taken, as soon as the impression body is dried in, the impression material should be wiped out, exposing the driver hole. And then the shortest driver should be used. Complete vertical remover is not easy because of the limitations in mouth opening. I just check whether it is moving vertically and remove the impression body. That's a good way. Based on my clinical experience, when the screw is completely loosened, it gives the sound of clink clink. Then I realize it is completely loosened, and I try to remove it with a pincet, and I remove it easily. Always with a pickup type, we need to check whether the screw is completely loosened to remove the impression body. That's a good way. Secondly, transfer impression coping is used quite often because it is easy to use, but sometimes the fixture analog and coping are connected and pushed into the impression body, and that needs to be fully pushed in, but sometimes it doesn't get pushed in fully. What are the reasons and how can we address the problem? In my opinion, the biggest part is that the driver hole is not blocked out for impression taking, and internally the impression body is slightly torn, and the body is connected as it is. Therefore, the best way to address the problem is we need to observe the driver hole. If it is not blocked out, you could take the portion out with a pinset, and if the impression body is torn a little bit under the bright light, you can remove it with a pinset. So we need to visually check the problem. If the problem is found, that needs to be removed, and that is pretty important. Based on my experience, visually we need to check that. Also, we need to listen. If you look at the transfer impression coping from OSSTEM, you will find 2 notches. As the notches are there, if you push them, click sound is heard. If you hear 1 click sound, it's not fully pushed in, so you should hear 2 clicks. So you'd better listen to that sound. I didn't know about that. I will take that tip, apply that from next time. Thank you. Next, third, in order to check whether the impression coping is inserted properly, often we check using periapical X-rays. By reading the X-ray, we can determine whether it is properly inserted or not. What do we need to be careful about in reading the X-ray images? Actually, when I take the X-ray images, whether there is a gap near the Morse taper or any problems, that is determined based on my clinical experience. It is very difficult to explain it to others. How do you do that yourself, Professor? We have prepared some slides, and let's talk about it by looking at the slide. Now it is displayed. If you look at here, there is the screw, and in the gap, there are 2 small eyes and a mouth below. If it is not fully inserted, the size of eyes and the mouth look bigger, and this is the X-ray after correction. 2 eyes and the mouth compared to the left is reduced. So as you can see here, we can check whether there is a big gap or not to determine whether it is fully inserted or not. These 2 eyes here and the mouth below look like the features of a devil. So when it is not fully inserted, the devil's eyes and mouth got bigger. So that is the criteria in reading the X-ray. That's the method I use. And there is a last question to Dr. Park. You use the one-guided system, as you explained in many cases. Digital dentistry, including the one guide, is set to be in the mainstream in the future, and many doctors who have used it seem like it very much. What is the reason behind that, do you think? I believe that the outcome would be better if you use the digital dentistry because people can make mistake. And Professor Cho Hyun always emphasized the importance of top-down process. I believe this fits that process and it will be advanced far more in the future. I believe in the near future, all the dentists will adopt the one guide or the digital dentistry. I agree. And we have received questions in real time. A smart fit is more precise according to the gingiva fit, but you use stuck abutments a lot. Is there any differences in terms of prognosis? Is there any reason why you are using stuck abutment a lot? For the insurance implant, I use the stuck abutment. That is my first choice. The reason is that recommending an abutment not covered by insurance to a patient who wants an implant under insurance is not appropriate. And if you use a stuck abutment, if the positioning is not very good, the shape will become really poor. Therefore, if you use a guide, the scope of using stuck abutments would be broadened. In terms of the shape, custom abutment is absolutely good. However, if you use OSSTEM's 1-feet abutment, without a doubt, it is good. However, if you use compatible products, I believe the stability of connection is very important. I can rely on the stuck abutment and OSSTEM's 1-feet abutment. Other than that, I don't completely trust them. So I move slowly in terms of incorporating others. Thank you. You still use custom abutment quite a lot, right? Yes, I use custom abutment for all anterior cases. That's right, for the shape or the health of gingiva. It is used quite a lot. We have to deal with a lot of implants under insurance. And if you use the custom abutment, the patient burden would be increased. Therefore, we use stuck abutments quite a lot. But in the case of the dentist who sent us the question, if it is not for insurance, I believe we can recommend custom abutment to the patient. I think so too. I have another question. So we have many questions for Dr. Park Jong-hyun. If I find the connection between the abutment and the fixture is not properly done, how can I deal with the problem? Is there a tip to detect such improper connection problem? For the connection problem, I believe there are about 3 reasons. The most frequent or the biggest problem is the mismatch of the hex. As Professor Cho said before, you need to feel the click when the hex is connected. Then a lot of problems can be avoided. And when you get used to it, you will detect the devil's eyes when the implant and abutment are connected, even though the X-ray is not taken perfectly. There is another reason for the connection problem. An abutment is not connected properly because of the bone interference. A slender form of 1-feet abutment helps. If that problem occurs, if you use a temporary, you will have another chance to check that error. Thank you very much. Good answer. For the proper connection of the hexagon, we need to check the feeling when the screw is inserted, whether you can feel the clean fit. And I always check X-ray to detect any misfit. If a misfit is already happening, a temporary can be used to detect the mistake one more time. When the final prosthesis is delivered to us, and if we find a misfit, we need to fabricate it again. Occlusal adjustment would not be good enough, so we need to take impression again and get the final prosthesis made again. Another question, you talked about compatible impression coping and scan body, the things we need to be careful about. How about compatible custom abutment? I am keenly interested in this subject. If you look at papers, they say compatible custom abutments are not very good, and such manufacturers disappear and new companies emerge, and they say ours is okay, ours has no problem, and it repeats the process. But I believe if you use the authentic original products, you will receive much less stress. That's why I use the authentic original products. Recently, I have used certain products and analyzed the products, and the results show, compared to the original authentic products, the compatible ones have many problems according to the observation conducted together with OSSTEM's R&D Center. If opportunity comes, I will talk about it next time. If you have such data, I'm sure we'll have another opportunity for you to share that data with us. Now we have another question. Do you use a screw type for TS? I like TS type. What's the advantages and disadvantages compared to the cement type? Screw type of TS. First of all, I don't like the screw type very much because if it is a gold cast abutment, the oxide layer is not much, so it is not too bad. But if you use metal cast abutment and remove the oxide layer of the connection, the stability of the connection would be lowered. So I believe the most important thing when it comes to a prosthesis is the connection. Thus, I like to use the stock abutments rather than the compatible custom abutment. So I think the screw type has lower connection stability. Another problem, if you use a single, then contact adjustments can be made. However, if you are dealing with a multiple case, the contact of the internal conical connection is very tight. From 2 or more, I think it's almost impossible to connect. Therefore, I don't like the screw type for stability of the connection. So you connect it, and then the impression is taken to fabricate the prosthesis, and you like the cementation type because it is more accurate. Even with the fixture level, if abutment can be connected without any interference, prosthesis can be fabricated in ER type or cementation type. Okay, next time I will invite a doctor who prefers to use the screw type, and after hearing to the screw type preference, maybe you will give us another response to that. Dr. Park talked about accurate connection of the abutment, and you prefer to use the cementation type. One more question. You are merging the image scanned by the lab in advance. Does that mean the lab should purchase a special program? In the lab, to do the CAD/CAM work, ExoCAD or 3Shape program, I believe they use such programs. I have not used ExoCAD. If a lab uses a 3Shape program, the merge can be done. I'm not sure But if they use exocad, I don't believe there is any difficulties in the merge. I believe the labs already have such programs, so we don't need to have such programs ourselves. That's correct. I think this answers the question. Due to constraint of time, we received many questions, but we need to close Q&A session here. Lastly, do you have any tips or advices to the colleague doctors in taking impressions for implants? I don't think there's one best impression-taking approach. If one is familiar with a certain approach, after trying this and that, if an approach requires least chair time, whether it be pick-up impression coping, transfer impression coping, or abutment level impression or digital scanning, it doesn't matter as long as the connection is right, margin is right, contact is right. So whatever the method may be, if one is familiarized with that and if one understands the logical rationale behind it, there'll be no problem. Thank you very much. Dr. Park Jong-hyun, I appreciate what you have discussed today. Thank you very much. Thank you very much. Next time, on the 25th September, on Friday, we'll invite Professor Lee Jun-sup of Prosthodontics, Dankook University. Will talk about functional posterior implant prosthesis. Thank you very much for watching us.